going to go is the most important is these seizures. Now, neurological emergencies, a neonate comes to an emergency with seizures. Basically, it can be a primary seizure disorder or it can be a secondary seizure disorder. The secondary seizure disorder is related to most of the problems which we face in the newborns. That is a baby who is having a metabolic abnormality, that is hypoglycemia, hypocalcemia, hypokalemia can come in a seizure episode. A baby who is basically having involuntary metabolism can come in a seizure. A baby who's in sepsis can come in a seizure. A baby who's had a trauma can come with an intracranial bleed and a seizure. So they are the secondary, secondary seizures and primary seizures as we see in cases of your involuntary metabolism. So that is what you have to think about. Now, the seizures are more frequent in the preterm infants because of HIE when they are having an hypoxic insult during the resuscitation. Abnormal movements occur secondary to withdrawal from maternal drug exposures, commonly opioids. What are the clinical features? We all know. I'm not going into details. Now, the causes of neonatal seizures in the first day of life: hypoxic insult, hypoglycemia, like I told you, metabolic abnormalities, any drugs, sepsis, trauma which leads to intracranial hemorrhages, pyridoxine deficiencies. Then we go ahead, second day of life, benign familial neonatal seizures, which will be a primary cause, benign idiopathic neonatal seizures, a primary cause of a seizure again. Then congenital anomalies and developmental brain disorders, which can cause primary seizures again. Drug withdrawals, infections, hyperphosphatemias, hypertension, hypocalcemia, trauma, and hyponatremia. These are the metabolic abnormalities. Now, investigation, you have to understand, first of all, whenever a baby who is coming into an emergency with seizures, first and the foremost thing is, with all the regular investigations which you are sending, do send a blood gas, number one. Do send all the electrolytes. Get a blood sugar level done, get a serum calcium level done, the potassium level done, phosphatase levels done, get a septic profile done. Once we have all those things, rule out whether the baby was having any problems because of this maternal, metabolic abnormalities. If that is the cause of seizure, treat them accordingly, treat hypoglycemia, treat hypokalemia, treat hypocalcemia, and then go further ahead. If you find that there is any history of a trauma, get a CT scan done or a cranial ultrasound at least as an emergency done. So maternal history, maternal medication, maternal infection, birth history, which is very important. Get a head imaging done. Infectious workup, CSF studies should also be performed. Urine and a meconium toxicology screens should be done. Now, management of a seizure. Now, there's a lot of confusion right now. How do we manage a seizure if a baby comes ahead in an emergency? Now, if a baby comes in an emergency, in pediatric population, the first line of a drug, I would say anti-epileptic drug, is phenytoin. Obviously, once we have given lorazepam and diazepam and whatever the initial management is. So the first thing in pediatric population is to give phenytoin, and then go ahead with levetiracetam, then go ahead with phenobarb, and then go ahead with ventilation and all those things. But in cases of newborn seizures, what the first management is, after we give diazepam or lorazepam, which is at a dose of 0.3 to 0.5 mg per kg per dose, you can repeat it to a maximum of 0.5 mg per kg per dose to 1 mg per kg per dose. Even after that, if the seizures are not getting under control, the first line is to go with phenobarbital, which can be given at a dose of 15 milligram per kilogram per day per dose, which can be increased to 20 milligram per kilogram per dose. If the seizures do not subside after that, then you go ahead and give levetiracetam, which can be again given at a dose of 20 to 30 mg per kg per dose stat, and then maintenance of a 5 mg per kg per dose. If that also does not subside the seizure, then you can think about going with valparin or maybe phenobarbital, but phenytoin, that can be then started. So same thing, first go with the ABCs, manage the ABCs. If the respiratory system is compromised, like I told you, start with supplemental oxygen with nasal prongs, get a blood sugar measurement done. Hypoglycemia, treat hypoglycemia, as I told you. Lab test, if metabolic disorder is there, treat accordingly. Get the hematocrit, electrolytes, blood urea, nitrogen, phosphate, ammonia levels, and blood cultures, and get a CSF done. The first, like I told you, is lorazepam. Then comes is phenobarbital. Then comes is phenytoin or a phospheniton. And then if you find that there are refractory status epilepticus, then first secure the airway, start midazolam infusion, and then shift the patient to a PICU for further care and management. If if you have done all the seizure protocol management, and you find that this child is still in status epilepticus, then you think about go with pyridoxine, vitamin B6. That is to be done, and acyclovir can be added in cases of your viral encephalitis. Now, these are neonatal seizures with withdrawal syndromes. Nothing much to be done, but normally, like I told you, the diagnosis is important. Clinical history and clinical examination and presentation of a baby. Get an EEG done, get an infectious workup done, and ultrasound and CT scan done. First, lorazepam, phenobarb, phospheniton, valparin, or levetiracetam, whatever you prefer. Then you can go ahead with this.